trauma-informed care as a universal precaution. Very basic objectives. I think kind of based on the audience here today, I really kind of want to focus on the strategies. I always know that when I walk away from presentations, if I have something I can use or a nice little reminder, it's really helpful. So hopefully I can give you one or two, or if you know everything, that's great. Maybe you can share this then with other people, because that's kind of another goal too. I did not put in here, but I am not receiving any financial reimbursement, and I am not biased in this. This is just something that I'm pretty interested in. I have training as a trauma-focused CBT counselor in the past, so trauma has been very, very interesting. I think Nicole did a wonderful job really talking about today that today is a kind of an interesting day to be presenting on this topic, because if you turn on the news or you look at any social media, there's a lot of pictures, and it's, you know, to show the gravity of the situation that 9/11 was in the terrorist attack on America. But it's very, very difficult to see some of those pictures. And if you think about anybody that was there, or there's a vicarious trauma, which we'll talk about a little bit, or even people that have similar incidences, that those are assuming that we were all Americans and that was our first terrorist attack that we've lived through. That's not taking into account people that have immigrated from other countries and how that could be for us. So it's coming from a good place, and that's kind of the idea behind trauma-informed care. We don't think people are purposely traumatizing other people, but we want to be mindful that maybe there are some things we can do better. So trauma-informed care, I'm going to use the TIC in this presentation, but it's just an understanding of trauma and what it can look like in different settings. A lot of you are in the healthcare profession, and so again, this might be pretty simple for you guys, but we can talk about how we can make it broader within our offices and our colleagues and such as that. So we literally could look at this slide and this could be it. I'll go in a little bit more detail, but it's really that easy. Trauma-informed care is just making sure that we have an ecological and cultural lens, anticipating what some traumatic triggers could be and trying to avoid those. And the huge one is getting consumer participation. So you'll see that I use the word consumer, and that's based a lot on the SAMHSA research, and that makes it broader than our clients and patients. So of course, as you know, servants for our clients and patients, we want them to participate in their treatment, but there are other consumers involved. This can be referring agencies. This can be EMS and police that respond to your location. This can be the cleaning staff. Just making sure that everybody is engaged because they're part of your bigger program and they also impact the care. I want to make inherently clear, as many of you know, this is not trauma-specific services. So everybody can practice trauma-informed care, but that does not mean that you're providing trauma services. Care is not treatment. It's a good way to figure that one out. I think about trauma-informed care, that could be used in Target with a Target cashier. So their basic skills, again, kind of go back to those three in the previous slide. But so hopefully we can get a little bit more meatier. So first and foremost, we're going to talk about safety, which sounds pretty obvious. So there is physical safety, right? Reducing that threat of harm. But there are different things that you can do to really promote the safety. And so when we think about safety with trauma, it's consistency. So if you go to a doctor's office or to a counselor's office, knowing what to expect, knowing rules. People like rules. They know that if you're getting loud, you're going to get asked to leave the room. Don't talk loud on your cell phone because that might trigger somebody else. And so kind of having those consistent rules makes people feel safer. So if yelling really, really upsets me, but I can go to my primary care doctor and know that there's a rule that loud talking on the phone, you'll be asked to go step in the hallway, I'm going to feel a little bit safer there. You also want to minimize other risk within the environment. So common characteristics of trauma are feeling like you don't have power, less control, being trapped, feeling disempowered. So just thinking about the environment up in the corner of that square there, so a lot of times offices are small, but you know, making sure that they have access to leave the door if they needed to. Letting them choose chairs, which I know is so tricky. I have the chair I prefer in my office that I want to sit at, but For some reason, that chair might be better for someone who has a trauma history. It could be anything based on the color of the chair, the pillows you have, or the location to the door. So as much as you can, letting them choose the environment. Empowering them to say things, and that's two different ways. Sometimes when people are survivors, they don't feel like confronting or maybe necessarily sharing their stories, but welcoming that feedback, maybe responding how you would, responded to other people's feedback. And then there's these really like boring things that work really, really great. And then those comment cards. I know that they have one outside the gym here, and unfortunately it's like tucked in front of the person at the front desk. So people might not feel super safe filling that out in front of an employee. But if there's an anonymous way for people to provide that feedback, that can be empowering, and that makes them feel in control. And it can make them feel less trapped if they feel they're being listened to. Again, the autonomy, allowing them to make decisions, that again kind of goes back to that restoring power that they may have not had before. So again, safety can be anything within the environment, but also a lot of them being able to make choices and providing that feedback of what makes them feel safe, which leads me a lot to the next slide. When we think about trauma-informed care, we really want to be patient-centered or consumer-centered. So we all have our own culture, and so we view what behavior and standards and rules and treatment should look like. And while that's great, that's not great at the same time. And we need to make sure that our services are responsive. People's symptoms and behaviors typically originate from trauma. So I think sometimes remembering that. So if somebody gets really, really upset that someone in the waiting room is talking on the cell phone, instead of being like, wow, that person's really like on their high horse, think of that behavior as, oh my gosh, that might be a symptom of trauma, right? That loud noise might be a problem. If the person doesn't want to walk all the way to the back of the hall to your office, trying to figure out, are they just being difficult, or, I hate to say the word lazy, but there's something about walking back there that they just don't want to do. Think about why that's a problem for them. It could be stemming from their trauma. And so the context of your environments too. Why are they there? Are they there seeing you because they want to? And that kind of goes back to that empowerment stuff. Or are they doing that to fulfill an obligation, and honoring that, that in itself can be taking away the power. Then we talked a little bit about the behaviors originate from symptoms. And so really focusing then on the strengths. What would be, for you, how can we be successful in your treatment? What did you do to overcome your trauma? What have you been doing so far that works? And sometimes the things that work aren't the healthiest, but there's always something within those coping skills that you can take from it. So maybe going off on the receptionist when she messes up your appointment isn't the best way to respond. But at least they're being assertive and letting you know that that's something that is triggering further trauma. So how to, approaching that, saying, wow, that assertiveness is really helpful for us so that we know that it's important to you not to switch your session. But maybe this is a way to do it better, and kind of reviewing those rules you set at the beginning. So really focusing on what they're already doing right instead of what they're doing wrong. Because again, wrong is a sociocultural label. That's what we're viewing as difficult or inappropriate. But for them, that's their strength. So just another little quote. So this kind of goes a little bit along with that patient-centered. Sometimes you have people come in and like it's very clear that trauma is the issue, but it's not always an issue for that person. And that's kind of another thing too with trauma-informed care, is that sometimes people don't want to talk about things. I know right now we talk about with the California wildfires, and I have family in California, and we so often, when I talk to them, I'm like, hey, how are you holding up? Are you safe? And that's just me, actually caring about them and stuff. And because it's a very traumatic, scary thing, they might not want to talk about it. And that's their right. Is there, could be avoidance, or maybe it's not traumatic. My uncle has lived in California almost all his life, and like that's his typical, like he knows when to evacuate. He knows where, he has an apartment reserved when he does have to evacuate, where it'd be very traumatic for me, but since we don't see it, it's not necessarily trauma for them. But then that's obviously a big trauma, but then we talk about other things that like maybe I don't think is traumatic, but other people are really, really impacted by. And that can be from their background, that can be just their experience personally that's reminding them of that. And so being, mindful of that too, that trauma is different for everybody. And so, just because somebody, someone has divorced parents, and so when their therapist cancels a session or their therapist is leaving the agency, they get super upset, and that wouldn't necessarily upset me. You got to see that they're, and I have divorced parents. It's not comparing those two again. Drawing connections is really, really important. So these are the collaborative relationships, and this goes back to making people feel safe. Have the consumers participate, have clients participate, allow them to give feedback through surveys, or it can just be through your presence, right? If they don't like that the cleaning person started vacuuming while they were there because the loud noise bothered them, listen to them and see what you can do with that. Allow them to participate. A lot of times there's fundraisers and stuff that you are involved in. So we think about like the NAMI walk. It wouldn't be appropriate necessarily for me to invite a client to come work out with me, or participate in a fundraiser where it's just us working out. But we can all go to NAMI walk together, and that can be empowering for them. And then there's peer support. So that could be 12-12, AA, 12-step. That's more connected than two. And the reason we do that is because it can be traumatizing, going back to that power of experts with clients. We talked about that consumer, that they're talking to their receptionist and they are a consumer of their services. And that power differential could really, really shift and be uncomfortable. So sometimes it's been best to kind of connect those peer supports with that. Awareness is another wonderful one. And this is not just with the clients and stuff, because, we kind of talked about that being like, hey, this could be traumatic. But within the office, I talked about the cleaning people. This would be a good one then too, to engage your community partners. So if police and fire might be involved for multiple reasons, whether it's due to mental health crisis, a physical crisis, people have, physical ailments where they're called, let them know that like the police may be traumatizing if they're walking in the waiting room, even though they're not working with the clients in the waiting room, might be really, really traumatizing for them. So talking about like, hey, when you come in, don't go running in the door, or is there a back door? Same with EMS. At Neomed, we have found out that even if they come to Neomed, no matter what, even though they're like 2 minutes away from us, I think less than 2 minutes, maybe 2 seconds, they have to turn on their sirens. And sirens are very, very triggering for a lot of people. And even though it might not be an emergency, it might just come check some blood pressure, they have to turn those sirens on. So maybe you can learn that ahead of time so that you can let your clients, your patients, consumers know, hey, they have to come with their sirens on. I'm really, really sorry. But that's their protocol. And again, if you can kind of get them through the back. So that's familiarizing everybody, not just your office. Psychoeducation is great. That's for family, friends, you name it. I would love to psychoeducate anybody. So I think that's really, really good. Getting commitment from your organization, and that's a little bit harder sometimes. I think for us, most of us, again, are healthcare providers, so a little bit easier buy-in. But if people are working at Target, being able to reach out and say, it's really important for us to get these trainings. And then last but not least, we talk about the routine trauma screening, and that's for all clients and consumers. They might not be presenting with trauma symptoms, but occasionally just checking in with those, doing some screenings, because people change. Trauma is triggered. We talked about 9/11. People might not have thought about that, but they do every September. So kind of doing that and checking in with them. The last one, kind of really doing with our consumers and clients, is really focusing as trauma as the primary goal. And so instead of saying, a lot of times people struggle with the impact of PTSD and stuff because that gets associated with illness. Instead, focus on the wellness part of this. It's recovery. So really fostering those skills. What your self-care is wonderful. You've been doing amazing with self-care. You've been utilizing these coping strategies. This looks really good. Oh, I see you connected with the VA. Wonderful job. You really got those support networks, and just, and really encouraging that autonomy that was a couple slides ago. Normalize symptoms. So that's the other thing too, that I think a little acknowledge and normalize is hard for a lot of us. So if, I go back to the person getting really upset in the waiting room about the loud phone call. If we just ignore that and we're like, woof, that's going to make them feel more isolated, right? That's going to reaffirm that idea that their behavior is bad, it's inappropriate, and no one wants to help them. So a good way to acknowledge that is say, hey, you seemed pretty upset in the waiting room. And they can say, oh, I hate when people yell. Then you can say, okay, well, yeah, I can see that that could be upsetting. And yeah, a lot of people can get triggered by loud noises and stuff like that. Let me see if I can review those rules with that client, or I'll make sure that we kind of do a better job of that. So acknowledging that. Dr. Dougal's on this call and she shares a story, and I know I'm going to butcher it, but that she worked at a place where there was a picture behind the reception desk that was a client saw a demon in. So it, maybe a little bit more psychosis than it was trauma. But they did the right thing, and they ended up taking the picture down. So acknowledging, it doesn't mean you're agreeing with it, right? So Dr. Dougal, I don't think, saw a demon in it. But acknowledge that, yeah, maybe that could be scary, and some people do see things that they don't see, and then they responded to it. So that's kind of that. And then balance. And so that includes noticing other things that like sleep disturbance, eating, things like that, making sure that everything's taken care of, and not just the trauma itself. So that kind of trauma is primary, but all these other health benefits are important too. So that's that one. So last slide, but the most important slide, if you ask me, is promoting the self-care. There is a lot of research that has been out, and I imagine after this pandemic, there's going to be a lot more about self-care within providers. So there's this idea of secondary trauma, which differs a little bit from some other definitions, but really making sure that we promote self-care, and that, sometimes trauma is an occupational hazard, whether seeing it firsthand. So sometimes if you see clients that, pass away or majorly hurt, or are violent themselves, that can be a little bit traumatizing. Or there's the idea of vicarious trauma, that hearing about stuff enough can it's not the best feeling. And so making sure that we're taking care of each other, and that's everybody, that is not just providers, that is checking in with your program coordinator and making sure that they're feeling okay. And if there was a situation that they're responded to, supervisors, making sure your supervisees, how are you feeling? How are you doing? Everybody has a past. You don't know if that past has trauma in it. And so if they respond differently to something, it might be related to that past, and they're not obligated to tell you, but making sure that you have the opportunity for them to check in. Obviously training like these, echoes are wonderful, but there could be more in-depth training. And then there's the big ones. Get yourself therapy if you need therapy. Just like if you're a physician, you're getting sick, you better go to the doctor. It's that simple, and making sure that you're taking care of yourself. Balance. If a big thing happens, know when to call it. We talk so much, again, kind of going back to the pandemic, that mental health workers did not stop. There was a lot of praise for doctors and nurses and firefighters and police, which are absolutely warranted, absolutely. But there were people that were forgotten, and so making sure that that hey, maybe this is really hard for me. I need to take some vacation time, or I need to take some personal time, or I'm going to have a mental health day myself. Knowing how to do that and having those balance. Another one is that setting those clear limits. And this is also good for you, but also good for your consumers. If you work 8 to 5, you work 8 to 5. Do not stretch that. That inconsistency can really mess with that safety feeling that consumers can have. And then pretty soon it's going to end up messing with your own safety. So really making sure that those boundaries are strong. But out of all the slides, I think this is the one that is the most important, and also the one that we like to forget the most, because we're so patient-centered and we're so consumer-focused, but we're not going to be any good to anybody else unless we're good to ourselves. So that is that. Here is my references, and I'd be glad, and I believe these are going to be sent out.